Welcome back to the Deep Dive. It is Monday, February 2nd, 2026. I want to start today with a word that, for most of us, carries. Well, it just carries a ton of weight. Cancer. We all have a relationship with it, whether we want to or not. And for as long as I can remember, the phrase cancer vaccine has been this sort of mythical concept. It's like the flying car of medicine.
Yeah,
We hear about it, we want it to be true, but it always feels like it's 10 years away.
it has, yeah. It's been a landscape of really high hopes and historically some pretty crushing disappointments. It's a buzzword that, has often failed to deliver.
That is exactly how I felt until I opened my newsfeed this past Friday.
Mm.
I saw a headline from Duke Health that I swear I had to read it 3 times. I thought it was a typo. It was reporting on a trial for metastatic breast cancer, so the kind that is spread, the kind that is usually considered terminal.
Or at least a chronic, life-limiting condition.
Exactly. And this trial started over 20 years ago.
Yeah.
The headline wasn't about, extended survival or improved metrics.
No, the headline was about life.
It said that of the women in this one specific group who received this vaccine 2 decades ago, every single one of them is still alive today.
It's a statistic that just stops you in your tracks. I mean, in oncology, especially with metastatic disease, we measure success in months, sometimes in single-digit years. So to look back across a 20-year horizon and see 100% survival, that's not just a success. It's a paradigm shift.
Hold on, let's just sit with that. Every single one. Because usually when we talk about metastatic breast cancer, the whole conversation is about management. It's about buying time. You're telling me these women are just living their lives, going to the grocery store 20 years later.
They are, and that's really why we're doing this deep dive today. Because when you look at the stack of research from just the last few weeks, from Duke, from the Cleveland Clinic, from Moderna, it feels like we're not just looking at isolated flukes anymore. We're looking at a fundamental change in how we treat and maybe even prevent cancer.
So the mission today is to figure out why now, what changed. Let's start with that Duke Health study, because this really is the miracle case. It was led by Dr. Herbert Kim Lyerly. They treated these women 20 years ago. Why did it work for them when so many others failed?
That is the exact question the researchers asked. I mean, survival like that over 2 decades it's extremely uncommon. So naturally, they went back to the freezer. They looked at old blood samples, the immune profiles of these women, to figure out what their bodies were doing differently. And they found that these patients didn't just have a temporary immune reaction. They possessed long-lasting memory cells.
Okay, memory cells. So that just means the immune system remembers what the cancer looks like.
Precisely. Think of it like a wanted poster. Most treatments, they tear down the poster after a few months. But in these women, the immune system kept that poster on the wall for 20 years. It never stopped looking for the fugitive.
This is where I get a little confused, though. I always thought the immune system was like a SWAT team. You have the killer cells, CD8 cells, I think they're called.
That's right, CD8 plus play.
And their job is to just kick down the door and, take out the bad guys. So haven't we just been trying to make those SWAT teams bigger and angrier for the last 20 years?
That's a great analogy, and you've hit on exactly why so many previous attempts didn't work. For decades, the dogma was CD8 or bust. Billions of dollars spent trying to boost those CD8 plus killer T cells. The logic seems sound, right? If you want to kill a tumor, send in more killers. But the Duke study found something that, well, it flips that logic completely upside down.
What do they find?
They found that the secret to this 20-year survival wasn't the SWAT team. It was the CD4 plus helper T cells.
Helper cells. That sounds underwhelming. Like the person who brings donuts to the stakeout. You're saying the helpers are the heroes.
Helper is a terrible name for what they do. Don't think of them as the intern with the donuts. Think of them as the generals. High-level battlefield intelligence.
Okay, that's a better rebrand.
Right. If you just send in the SWAT team, the CD8s, without a general, they go in, they attack, and then they get exhausted. They burn out. It's a phenomenon we actually call T-cell exhaustion. The tumor fights back, the killers give up. But the Duke team found that the CD4 cells, the generals, they're the ones who keep the mission alive. They coordinate the attack, they tell the killers where to go, and most importantly, they tell them, do not give up.
So without the general, the soldiers just get tired and go home.
Essentially, yes. And in this study, the survivors had these incredibly potent generals. Specifically, their cells had a marker called CD27.
CD27, is that like a switch or a flag?
It's a receptor. It's basically the mechanism that helps the immune system maintain that long-term memory. And this is the part we can actually act on. The researchers realized that if they could stimulate CD27 artificially, they could wake up these generals in other patients.
And they tested this in mice, right? Looking at the numbers here, the difference
And
is it's just staggering.
it is night and day. They used a HER2 vaccine. That's a common target in breast cancer. When they gave the vaccine alone, just trying to stimulate the killers directly, they saw tumor elimination in only 6% of the mice.
6%. I mean,
Okay.
that's basically a failure.
It's very poor, yes. But then they added an antibody to boost CD27 to wake up the generals, and the elimination rate jumped to nearly 40%. And when they combined that with support for the killer cells, the rejection rate hit nearly 90%.
From 6% to 90, just by making sure the generals were awake to command the troops.
And the beauty of this is that the CD27 antibody only needs to be given once, at the time of vaccination. It's not a pill for the rest of your life. It's a one-time briefing for the generals. This is the enemy. Never forget.
That's incredible. So that's the treatment side, taking someone who's already sick and giving them a full life. But I want to pivot to the other side of this, which honestly feels even more sci-fi: prevention. Because curing cancer is amazing, but stopping it from ever showing up, that's the real dream.
Absolutely. And that brings us to the news from the Cleveland Clinic, specifically about triple-negative breast cancer.
Right. And for listeners who might not know, triple negative is, it's the bad one. It's aggressive, spreads fast, and it doesn't have the hormone receptors that other drugs can target.
Oh.
It also disproportionately affects Black women and women with BRCA1 mutations. So preventing this one is a huge priority.
It is the holy grail of breast cancer prevention. And the Cleveland Clinic just presented their phase 1 final results in December. They're using what they call a retired protein strategy.
I love this phrase, retired protein.
Yeah.
What are we talking about biologically?
So the vaccine targets a protein called alpha-lactalbumin. This is a lactation protein. Under normal circumstances, a woman's body only produces this protein when she's breastfeeding. That's its only job. Once she moves past childbearing age, that protein retires.
Okay.
It disappears from healthy breast tissue. It shouldn't be there.
Okay, so it's gone, but I'm guessing it comes back.
That's the key. For some reason, alpha-lactalbumin reappears in most triple-negative breast cancers. So the logic is, brilliant in its simplicity. You vaccinate the patient against this protein.
But wait, I have to play devil's advocate here. We're talking about vaccinating healthy women, right? Women who don't have cancer yet.
Correct. That's the ultimate goal.
That just sounds incredibly risky. I mean, biology is messy. If you train the immune system to attack this protein, how can we be sure it won't get confused and attack healthy tissue? What if the protein isn't as retired as we think?
That is the single biggest question, and it's why this was a phase 1 trial. Phase 1 is all about safety. Look, if you're treating someone with stage 4 cancer, you might accept some collateral damage. But if you're treating a healthy person to prevent cancer, your tolerance for side effects is basically zero. You can't cause an autoimmune disease.
What happened? Did the immune system behave?
It did. They tested it on a few groups, including cancer-free women with high genetic risk who'd already had preventative mastectomies. They found that 74% of them showed a strong immune response. And crucially, the side effects were mild. Mostly just skin irritation at the injection site. No autoimmune attacks.
Wow, okay, that is a massive relief.
It completely validates the retired protein hypothesis. The immune system saw the protein as foreign because, well, in a non-lactating woman, it is foreign. It's a target that shows up on the tumor, but nowhere else.
So it's like setting a trap that only the burglar can trigger because the homeowner never touches that specific window.
That's a great way to put it. And since they've cleared that safety hurdle, they're expecting to start phase 2 later this year in 2026. This is moving from a very clever theory to a clinical reality.
It's so hopeful. Now, speaking of moving from theory to reality, we have to talk about the technology itself, mRNA. We all know mRNA from the COVID years. But I remember back then, people were saying, this tech will cure cancer one day. But then, we also saw COVID immunity waned. We needed boosters. So when I see mRNA for cancer, I worry. Is this going to be a shot we need every Tuesday?
That's a very valid concern. Viral immunity and cancer immunity are different beasts. But on January 23rd, just over a week ago, Moderna and Merck dropped 5-year survival data that suggests, well, that durability is achievable.
This is for melanoma, right?
Yes, a phase 2b trial for high-risk melanoma. They gave patients an mRNA cancer vaccine combined with Keytruda, which is a standard immunotherapy drug. It sort of takes the brakes off the immune system.
And the results after 5 years.
The combination reduced the risk of relapse or death by 49% compared to Keytruda alone.
49%. You're saying it cut the risk in half. And this is 5 years out.
That's the gold standard. In oncology, if you're seeing that kind of sustained benefit at 5 years, it is not a fluke. It means the immune system has fundamentally learned the lesson. It hasn't forgotten the cancer. It's like our bodies sometimes forget a virus. The combination of the specific mRNA instruction and the checkpoint inhibitor seems to create a very durable memory.
It really feels like we're entering a new era, but I want to complicate things a little because as smart as we are getting, cancer is unfortunately really smart too. It mutates, it evolves. One of the biggest heartbreaks is drug resistance. You hit the cancer with chemo, it shrinks, and then 6 months later it's figured out a way to survive and comes back even harder.
That's the tragedy of oncology. You buy time, but the cancer adapts. It's an evolutionary machine. But there is some fascinating work coming out of the Institute of Cancer Research in London that's trying to turn that very adaptation against the cancer.
This is what I've heard called the judo move of cancer treatment, using the opponent's strength against them. How does that work?
They're looking at cancers with BRCA mutations, so-called HR defective cancers. When we treat these with drugs like PRP inhibitors, the drugs work by breaking the cancer's DNA. The cancer dies because it can't repair itself.
Okay, simple enough. Break the DNA, kill the cell.
But in resistant cancers, the tumor pulls a desperate move. It undergoes what are called reversion mutations. Basically, the cancer realizes, hey, my DNA repair shop is broken, that's why I'm dying. So it frantically tries to glue its own repair mechanism back together so it can survive the drug.
It's trying to fix the machine while the machine is running.
Exactly. But here's the catch. When the cancer does this frantic gluing job, it's sloppy. It creates a scar. And that scar creates a new protein sequence, a neoantigen, that has never been seen before in the body.
So by trying to save itself, it creates a brand new target.
Yes, think of it like a criminal trying to change the locks on his hideout to keep the police out. But in his panic, he installs a neon pink lock that glows in the dark.
And the police, the vaccine, can see that pink lock from a mile away.
Precisely. The researchers are developing vaccines that target these specific resistance flags. So we aren't just vaccinating against the original cancer. We are vaccinating against the disguise the cancer puts on to hide from the drugs.
That's just incredibly clever. It traps the tumor. If it doesn't mutate, the drug kills it. If it does mutate, the vaccine kills it.
That's the goal. We're finally checking the cancer's escape route.
Now, obviously, these vaccines take time to roll out. Phase 2, Phase 3, that takes years. But for people listening who might be dealing with this right now, we can't just wait for 2030. There were some immediate FDA updates this month that sort of act as a bridge to this future. What's happening in the clinic today?
The FDA has been very active. We saw a priority review granted for a drug called gedatolisib. It's for advanced HR-positive breast cancer. It blocks a key growth pathway. We should get a decision by July.
And we also saw news about Trodelvy becoming a new standard of care.
Yes. Combined with Keytruda for triple negative, it reduced the risk of death by 35% in phase 3 trials. So, these aren't vaccines, but they are better, smarter weapons we can use right now while this other technology matures.
There was one other update I think is so crucial for quality of life. The Breast Cancer Index, or BCI. The guidelines were updated to say this is the only test to predict if a patient benefits from extended endocrine therapy. Can you explain why that matters? Because extended therapy just sounds like taking a pill.
It sounds simple, but for many women, those pills are miserable. We're talking about hormone blockers they might take for 5, sometimes 10 years. They cause joint pain, fatigue, bone density loss. It significantly affects your daily life.
Right, so women are sitting there thinking, do I really need to feel this terrible for another 5 years? Is it even doing anything?
Exactly. And until recently, it was a guessing game. The BCI test changes that. It can give a definitive answer. It can tell a woman, you will not benefit from 5 more years of this. You can stop. And that is just a massive gift of quality of life.
That is huge. It's not just about living longer. It's about living better. Before we wrap up, I want to try to synthesize all of this. We started with a 20-year survival miracle at Duke. We looked at retired proteins, mRNA, durability. It feels like the whole narrative of cancer treatment is fundamentally shifting.
It is. For a century, the story was about external force. Surgery, radiation, chemo. We were trying to blast the cancer out of the body. The new narrative is about internal instruction. We're teaching the body's immune system, the generals, how to do the job they were evolved to do. We're finding the keys like CD27 or alpha-lactalbumin that unlock the body's own power to heal itself.
And it's moving from mice and theory to real people living 20 years past a metastatic diagnosis. That gives me chills.
It should. It represents the maturation of immune oncology. We are moving from the hype phase to the proof phase.
So here's a final thought to leave you with. We talked about that retired protein, alpha-lactalbumin. A protein that serves a purpose for a little while and then goes away, making it this perfect target when it reappears in cancer.
Huh.
It just makes you wonder, what else is hiding in our biology?
That is the billion-dollar question.
Right. If we can vaccinate against a retired milk protein because it shouldn't be there, what other obsolete biological markers are our bodies holding on to? Are there proteins from when we were embryos? From puberty? What other ghosts are floating around in our cells that could be the next target for curing not just breast cancer, but, I don't know, pancreatic cancer or glioblastoma?
It's a fascinating concept. They're called developmental antigens, and yes, we are just scratching the surface. We might be walking around with the keys to our own cure, hidden away in our junk DNA, just waiting for us to notice they're out of place.
Something to mull over. We will be keeping a close eye on that Phase 2 trial at Cleveland Clinic later this year. Thanks for diving in with us.
It was a pleasure.
We'll see you next time on The Deep Dive.